central hospitals have hospitals, all of them have considered that corruption do exist in their institutions. Chirazuro District Council and Tiolo District Council have learned about the existence of corruption through the media. Like I said, they haven't told us anything that they've done so far. And we are aware of the existence of the ombudsman in their institutions. These are some of the issues that you need to note as you are preparing for your questions. But before I hand over to you, do you still have something to say, SH, or we can go straight into plenary?
Chair, we can go straight into plenary.
Thank you very much. Honorable members, time for plenary questions, comments, and observations. We go to Mzimba Perekezi. From Mzimba Perekezi, we go to Mangochi West. From Mangochi West, we go to Kata, we go to Chitipa South. From Chitipa South, we go to Cholo, Konjeni, Magunda. In that order, please. Thank you.
Thank you, Chair, for giving the people of Mzimba Perekezi this chance to ask some questions. First of all, let me thank all the presenters for their insightful presentations. I just have 2 questions. The first one is it goes to all the health centers, or all public hospitals, even to the Ministry of Health. Share the inquiry has revealed that organized extortion networks were operating openly within the hospital premises. How is it possible that management systems could not detect these practices before journalists? That's the first question. My second one goes to Muzuzu Central Hospital. Following the installation of CCTVs at Muzuzu Central Hospital, what measurable reductions have been observed in medicine losses and authorized access to the medical store? I submit, Chair.
Thank you very much. In Zimbabwe, we go to Mangochi West.
Chair, thank you. And let me join my friend to thank all the presenters for the good presentation and the honesty which is there. Mainly specifically, it will go to Doc, presented for KCH, and to the Principal Secretary. And firstly, Doc did really acknowledge that there are cases of corruption being reported, and some of the perpetrators were identified, but some were failed to be identified just because they were failed to be mentioned by the patient themselves. Now, I would like to ask Doc, don't you think that maybe it's a good time that our doctors and all health workers must be put on name tags as well as IDs to make sure that patients can easily identify them and maybe just write their name and put in the suggestion box so that the perpetrators can be easily identified. And on the same issue, just because it shows that it's cross to all central hospitals, I would like to ask the PS that what holistic approach can we employ to make sure that our health workers are being identified, so that if patients are being victimized, they must be easily being identified. For your own attendance, Chair, the last question going to the PS is about from Rikoma. The reporter did mention that one of the patients which presented the report about corruption was a Mozambican resident, and they look into the amount of money that are used for referral from Orikoma to Mzuzu. They say it's more than 3 million for one referral. But the budget which is being given to them is focusing to the population of Orikoma itself. Now, as a policy holder, PS, don't you think that this is a good time that in our bordering districts, our patients needs to use their national IDs for them to be identified as citizens of Malawi, so that if we do have some other citizens for other countries, they need to pay for our services. Thank you, Chair.
Thank you very much. The people of Mangwaji West will go to Chitipa South.
Thank you so much, Honorable Chairperson, for granting the floor to the people of Chitipa South to ask 2 questions. One going to the DG for Kambu Central Hospital, and indeed to the DG for Queen Elizabeth Central Hospital. Suffice to learn that we had a case of pharmacists who were referred to police and indeed to the regulator. Following the same, I want to find out if the case which the minister herself visited the facility, Kambu Central Hospital, I want to learn from the Director General if the officer who was finally suspended was a elected officer or indeed a lower level officer. Asking this because I didn't hear the DG mentioning that the officer was also sent to the regulator for the disciplinary hearing. This is a regulator's disciplinary hearing. Again, at the Queen Elizabeth Central Hospital, the DG mentioned that there was a case of an officer who was dismissed, and actually we saw a letter of dismissal. Also, I want to find out from the DG for Queens if this officer is that one who is regulated or indeed is a lower level person. So if this person is regulated, I wanted to find out if this matter was escalated to the regulator, be it Business Council, Pharmacy and Medicine Good Authority, or Medical Council, Malawi, or any other. Yeah, so apart from that, I also want to find out, do these issues go to the ACB or they just end at the level of one receiving a suspension or a dismissal? Because if it's confirmed that it is a corrupt practice, we should expect that the Anti-Corruption Bureau should take charge of that case. We didn't hear that from the 2 DGs, DG KSH as well as DG Queens, but we can hear the case of dismissal and suspension, meaning that these allegations were approved, but we didn't hear them escalating the matter to ACB. Chair, I submit.
Thank you very much. We go to the people of Cholo Konjeni Magunda.
Thank you, Chair. Let me accompany my fellow MPs that have applauded the presentations from all hospitals. My questions go to Mzuzu Hospital. In your presentation, you have mentioned that whistleblowers withdrew complaints out of fear of retaliation. How does this undermine efficiency in case of in case resolution, and what reforms are needed to protect witnesses and ensure timely investigations? Second question, what systematic efficiencies in cash collection and supervision allowed bypass fees and fake receipts to flourish? And how is Mzuzu Central Hospital actually addressing these loopholes? I submit, Chair. Thank you.
Thank you very much. I think we take those questions just to build on the question of the people of Chitipa South. So the Rikoma District Council has told us that about 55% of the people accessing healthcare services are from Mozambique. And apparently, it means if you have this figure, it means you know these people. Are they also having free access? Or what should we do as a country? And this can also be tackled by the SH. What can we do as a country to also start cashing in on these people who are coming into our country to having access freely for medical care services? And the other one, the case of Mr. GN from Kamu Central Hospital is very interesting. So 90,000 was paid and all parties involved accepted that 90,000 was paid, but all of them denied revealing the identity of those who were involved, and the case was closed. Just like that. Thank you very much. I think we can start with the SH and then we escalate to others.
Thank you very much, Honorable Chairperson and the committee. One thing we may just need to highlight is that we do, as a ministry, recognize and acknowledge that corruption exists, but also theft exists. I think there are two areas here. There's theft, there's corruption. In terms of reporting, corruption surely would go through the SEB and others. Theft will have a different direction, Chair. And comes from both angles, from service provider and the client. We have noted, Chair, that to a large extent, the client side only reports when something wrong has gone. I mean, something wrong has happened. So if they paid, whether it was agreed or not, and their expectations have not been met, or indeed there's an extra loss, that's when they will report. So meaning that there's a lot of underground corruption that is gone out. And if everything has gone right or expected, maybe they'll not report it. I'm highlighting this. Last time we had a visit to Mwanza with the Honorable Deputy Chair. And I think the main thing that came out of that case was that the child had died. So I think that's probably what prompted the family to come and say, we've paid, but we've lost the child. So it's a double loss. There are some questions, Chair, that have gone to specific controlling officers. I think those ones will be taken care of by them, and then I can comment on it later. The specific one for Likoma, which highlights what is happening in terms of service delivery to Malawian and non-Malawians. We have 29 districts in the country. About 24 of them are border districts. And what is happening across all the border districts is similar to what's happening in Likoma. So whenever you're giving us a budget, whatever it is for a district, about 40% in most of the districts is not serving Malawians. So that is a big problem, and highlighted yesterday by the other honorable members, including Chitipa. Chair, on this one, there was an issue or comment on the use of national identity cards. which is very welcome. It is being utilized. I think Kamo Central Hospital may comment on it, what they're doing, and even Queen Elizabeth Central Hospital, what they're doing in the cancer center or cancer management. That quite a number of patients that they're seeing there are non-Malawian. And therefore, there's a requirement for all patients to present national IDs. But, Chair, the Public Health Act that we were deliberating yesterday was stating that in emergencies, then we may not necessarily have to wait for someone to produce an ID. I think that's what is clear to all of us. And I think that might be a policy statement that may need to go out there. Our ID cards are only on people above the age of 18. And about 50 to 70% of our population is below 18. So, and those are also the majority that are seeking care, Chair. We were in Rwanda, and good that Parliament here has called us for this. Rwanda registers all newly borns. So any Rwandese has a number. And that's what we would like to implore upon Parliament, that all newborn children should have an ID number. So as they are born, they should have a number. And whenever they are attending any care, whether at school, health facility, they should be presenting that number. That number, Chair, can go on to the age of 18, where then that number is used to generate the ID card. I think that is feasible. Meaning that any time, even if we develop our digital health systems, then we're able to track to the last mile. So that can be done for all newly borns. The other children that are not, well, they're already born, then we can find spaces where they are. Could be primary school, could be secondary school. That can be done. What may be required, Chair, is Parliament sees the need, brings up the case. We see it as a big need. Brings up the case. It is budgeted for, and different spaces are reached through NRB. It can be a 1-year program, it can be 2 years program. We can finish and get all Malawians with a number. And that would help us a lot. We've brought it to our Honorable Minister. When we arrived from Rwanda, a memo was generated to the President, because we believe this is, so if Parliament can support this, it will be helpful that we all get all Malawians registered. I'll comment on some cases. I think there was a specific one for Lion Hospital, which the Honorable Minister showed. Those cases were presented to Ministry. They were all professionals with a regulator, and so all of them were sent to Medical Council. On top of that, they were sent to Health Service Commission. The Health Service Commission is the employer. So whatever happens, the councils would look at the professional side, licensing and all those sort of things. Health Service Commission will look at employment. Employing or dismissing or firing is Health Service Commission. We are constituting the commission, and I think in the next they'll be deliberating this case. Just to mention, Chair, that already the Health Service Commission has dismissed a number of staff. And I should have been able to share this. For regulators, Chair, we just mentioned that We have noted that it is only the medical council which publishes their disciplinary hearings and outcomes of the disciplinary hearings. We are now instructing Pharmacy Medicines Regulatory Authority to publish. We're also instructing Nurses Midwives Council to publish. It happens with the lawyers, it happens with medical council. It should also happen with the other regulators. The Health Service Commission will start publishing those that have been dismissed on disciplinary hearings. That has been settled, and I think this will be the standard of practice. I will just mention another area on uniforms. Yes, it's a requirement that all workers, whether professional or non-professional, are supposed to have name tags and identify their cadre. All are supposed to have uniforms. Maybe, Chair, that during this time we've not written again to the various facilities, but last time in around 2019 we did write to all facilities to ensure that all staff have uniforms. Our task as ministry is now to discuss with the various regulators on whether we may need to differentiate the uniform based on cadre and level. I'm mentioning this because sometimes you may not know that this is a medical student and this is a qualified worker. This is a consultant. This is an intern. I think that would require us talking to the regulators on defining which uniforms would have to be worn by which cadre. I think that's the next level that we as ministry are planning to do. Thank you, Chair.
Thank you very much. We go to KCH.
Thank you, Honorable Chair, and honorable members of the House, SH, and colleagues. So most of the questions, I think they have been addressed by SH. From Zimba, you asked two questions. One was a general question to all of us. Is it that it's the journalists who let the cat out of the bag in terms of corruption in these facilities? The answer is no. If you have observed, I reported cases as far back as 2024. And in my conclusion, I said the reporting systems in these facilities, they are working. What we need is to strengthen these systems and also to advocate for the masses to use these systems of reporting rather than reporting their cases on social media. On the same, however, I am not saying that you cannot investigate as a journalist. It is your job to make sure that certain things are known to the public. But in this case, these cases, the systems that MOH put in certain areas, they've been working, and these cases have been picked. Only that the issues you have seen is the gaps that we're talking about, where HR is involved, then there is level of SCP, then there is a level of court, then there is police level. As hospitals, we cannot prosecute anyone. Our responsibility is to put systems in place so that cases are reported and taken care of according to systems. In terms of Nzimba, I would like to agree with you that indeed it's a high time that apart from the uniforms and IDs, we need name tags. However, on name tags, we need to sit down and deliberate more, because we might have people being invited for questioning when they're not the ones who committed the crime. It is possible for someone to use my name and go into a certain facility as Amos. So all these things have to be looked into and make sure we vet enough before some of these things are implemented, because they could potentially harm other members. Case of DN, case closed. It's the same issue of steps. Ombudsman and Integrity Committee, they do investigations. And they also act fairly, depending on their standard operating procedures. So we can also not go in and tell them prosecute this one. That would be very personal. So we still follow, despite that cases have been reported, they followed the right procedure to make sure that justice has prevailed. Thank you so much.
Thank you very much. We go to Mzuzu, Queens.
Thank you very much, Chair. There was a specific question that was asked for Queens about the member of staff who was dismissed. So the process that has been outlined by the SH was followed. So the procedure is staff who grade M and L can be disciplined locally at the hospital. Grade K to F, it is sent to the Health Service Commission. And the staff who was dismissed, he was grade I, which is quite a senior level. He was handled by the Health Services Commission. There was a question on how we failed to identify organized networks. As a DG for KSH has said, these issues have been there for some time. It was just exposed at this point in time, but we have been handling this for a long time. And even for the dismissals, I had two others. I only reported on one. There were two others who have been dismissed and multiple others before. At Queens, having noticed this problem before, we have engaged the police to come in as unidentified people to help us identify the networks. That was done twice, but we failed to identify the networks. So these are quite sophisticated networks, and as the SH has said, usually people report when something goes wrong. If things are working for them, people would not report. And we've had patients who have been affected, and you ask them that, please show us who has done that. Even the patients themselves would not report, because they think if they report, then they'll not get the care that that person has promised them. Then another person cannot take care of them. So it is quite complicated. If you can allow me to comment on two issues which were raised, the issue about name tags and uniforms. The issue about uniforms for nurses is very clear. For doctors, sometimes we don't know what uniform they put on, but for nurses it's very clear. And like at Queens, it's our policy that every 2 years we should buy our nurses 2 uniforms. But where you are faced with budgetary constraints, where your ORT is small, you need to make a decision. Do I buy uniforms, or we buy fuel so that the ambulances are going to run and things like that. So the budgets that we are getting and the number of staff that we have are quite a big challenge. As I said, at Queens we have 1,600 employees. Getting 2 uniforms for each one of these, it is quite expensive, and the budgets cannot withstand that. Normally, the way we budget, when it comes out after the budget session, we find that most of the budgets have been cut out. And then when the funding comes, you find that not everything that was approved is funded. So it does limit us on things that we can do. If I can also comment, SH commented on that, on the people from, our brothers and sisters from Mozambique. It is a big problem because, us on the ground, most of these people are as poor as our fellow Malawians who we are offering free care for. So it becomes a problem. And our first president, Kamuzubanda, did say that these borders are not natural, yeah? They are man-made. So most of these are actually our brothers. So half the time we don't even need IDs, because we know who's from Mozambique and who is not. But you look at them and say, okay, we're going to pay. You see that they cannot pay. So apart from other measures, if they can be, if we can discuss with the Mozambican government, they accept that most of their patients in the borders are coming to our places. Queens doesn't have a border, but if you come to Queens, you find about 10% of our patients are from Mozambique. And so it may need more, because I think when they come, they're suffering, it's difficult to send them back, because I think most of them, we know they cannot pay. The way they look, they're just as good as our poor patients. They can't pay. So we need, I think we need something at a higher level, even with the governments, to discuss how we can fund this. But it is a challenge that we're facing, and it will be difficult to send them back, because, I mean, we are human, we know what we are dealing with. It is quite a challenge. Thank you, Chair.
Thank you very much. How would you want this issue to be addressed? Because the same poor Malawians, when they're in South Africa, they are made to pay for the services in there. But here, we are allowing Mozambicans, just because they are poor, just like poor Malawians living in Zambia, for example, they are paying for the services. How should we move on? I think one of our members will also come in. There was a question for Rikoma, but I think most of the issues have been addressed by the SH. Do you want to add some more meat to the responses by the SH?
Yes, Chair. Thank you.
Queens, would you switch off your mic?
Thank you so much for giving us this platform. And thank you, SH, for responding. But in addition to what SH has said, our observations are that almost 75% of our referrals are from Mozambique, because their health system along the borders are poor, and they are very far from the borders. So they come, present themselves to our facilities whilst the situation has deteriorated. And we currently discussing with MOH to digitalize, under digital health, to digitalize all people in Rikoma, then start piloting if we can request them to start paying. So we are discussing how we can go about it. Thank you, Chair.
Thank you very much. We go to Nkatabe North. Then from Nkatabe North, we go to Mwanza West. Mwanza West, we go to Dowa West. And then we conclude with the people of Chitipa North. And then we have Dowa Mpodzu. Last one is Kota Mkula. In that order, please. Yes?
Chair, point of order, Chair.
Thank you.
I posed 2 questions to Mzuzu Central Hospital.
Oh, thank you very much. Mzuzu Central Hospital, please.
From Mzuzu Central Hospital, for the general question, I think you have the response. I don't think I have to answer on that one. In the article, Mzuzu Central Hospital's name was mentioned, but not the details. But we still went back into our system to see what is going on. And like Mzuzu Central Hospital had said, these are processes that were already happening for us in terms of identification and management of cases. I was asked about CCTV, to say how much have we recovered or how much have we saved. So far, this is our 2nd month of installation of the CCTV. A CCTV which was a request from our specific high-risk areas to say, can you please install a CCTV because we're suspecting certain activities. So within the 2nd month, that's when we discovered that actually it was quite helpful for us. We have only had 1 incident as of now, and the amount that we have managed to recover, or the amount that has been calculated, is around 1.6 to 2 million kwacha. However, what has been very good about the CCTV is one, to identify the individual involved, so we have real and hard evidence. The second thing was also to see the cascade of reaction when someone has been caught. We have also identified who is high risk of taking medication and drugs from the pharmacy, so the major exit point. It has also helped for us to discover the pathway when the drugs leave the pharmacy. Where do they go? We discovered that actually it goes to a clerk's office, and upon opening of that clerk's office, we discovered it's an ongoing activity. For example, we found 96 big boxes for gloves. In each box is 10 set of gloves, which is 960 boxes of 100 gloves, which is about 96,000 gloves. So we can imagine what has been going on prior to that. We also found prescription bags, we found drugs, we found syringes. And the interesting thing also, we've discovered what are the high-risk commodities that are actually going out into the community. We've also discovered that it is a cartel. So it is not only the pharmacy assistants or the pharmacists that may be involved, we also have the maids involved. We also, through the CCTV tool, has seen that though we had certain measures put in, for example, we have told the security guard before anything leaves the pharmacy, can you check they have the book? Can you check, cross-check the commodities on the toll and the book? We saw that this security guard was not even paying attention. He just allowed the toll to pass. So in the way, this CCTV has just allowed us to understand the depth and the pathways that are used. And like I said about the whistleblower, because the consequence of someone saying something is happening, we have seen that there's a lot of protection within the facility of each other. So we feel like through the CCTV, we may not say actually the amount of money that it may save, but I think it has just revealed to us the depth of what is going on and what access points we should be able to shut down and to close. And I had a second question on the whistleblower. And I think if I'm not mistaken, when I said the whistleblowers were scared, we are assuming they're scared. I think, like I said, Mzuzu Central Hospital is different from other facilities. We are more or less like a community. Our assumption could just be maybe the whistleblower knows the person who is demanding the money, and they may fear community retaliation if that person is prosecuted or reprimanded. And also the second thing about the whistleblowers being scared, what we've discovered is our systems are not inefficient, but at least they're a bit more efficient. However, sometimes people just want to jump the line. And then they pay, and when things don't go their way, they complain. Unfortunately, I think they fear that they will be pointed to say, but you are the one that offered me the money, as if it was a two-way service, without understanding that any money that is paid at a public health facility that is free, whether someone has offered it or you have taken it, either way, it's not supposed to happen. You asked about what can be done about that. I think we need national legislation and internal guidelines. We can form the internal guidelines, but if these things are not backed up to protect the whistleblowers, it will be very difficult. And I keep talking about the example of the pharmacy technician who's now under a lot of heat. Some people fear that they may lose their jobs if the whistleblower against, let's say, the employer, or let's say against their manager, they may easily lose their jobs. So if we have national legislation against protecting people not to lose their jobs, protecting them if they've got a security risk, especially health workers and caregivers, and also protecting them from public consequences. You asked about the bypass fee in terms of the system efficiency when we discovered this. What we did was, yes, we installed CCTV where we collect money, but also we stopped money collection outside those that are in the accounting department. We have specific areas. We have informed all the health workers if they're treating people who are coming as bypass, they should have a government receipt with them. Without a government receipt, even if they pay, they will not be attended to. In that way, we're encouraging that patients should go to a point of payment rather than giving money to anybody. Also, over the weekend, we're paying people lunch allowances because there's shortage for the accountants. So we're giving them lunch allowances to come over the weekend so that at least they should continue generating, collecting the finances. Unfortunately, due to shortages in maternity and emergency, we have made a system which is not the best, where we record all the names of people who collect cash and then we give them a government receipt after. But the long-term expected solution would be that the health centers around us should be upgraded so that there should be no need for people to rush to Mzuzu Central Hospital because the health centers are smaller and are not managing. If we upgrade those health centers, then yes, we can do the gatekeeping the way Mzuzu Central Hospital does and Mzuzu Central Hospital does. Then the bypass fee collection will drastically on its own and automatically go down. And then also we're looking towards the digitalization, where we'll have banks coming in to be able to collect those bypass fees. I hope I've addressed all the questions.
Thank you very much. We go to Nkatabe North. From Nkatabe North, we go to Chitipa North. From Chitipa North, we go to the people of Doampudzu. From the people of Doampudzu, we go to Mwanza West. Then we finish off with the people of Nkhotakota Nkula. In that order, please.
Thank you, Chair, for giving people Nkatabe North to ask questions. My question will be general. Our first question is understaff. I think we are aware that I think most of the directors, they are complaining about understaffs. So the question is, how do staff shortage and low wages at Central and District Hospital correlate with the reported bribery incidents? Do you have internal analysis on this? Secondly, are patients informed of what services are free versus paid at the point of care? How is this communicated and enforced? Thank you, Chair.
Thank you very much. Simple and straightforward questions there. We go to Chitipa North.
Through you, Chair, thank you very much. And thank you for the presenters that have made quite elaborative presentations. My questions, I have two questions that goes to Queen Elizabeth Central Hospital. The first one, in your presentation, you talked like you have corruption prevention policy. So your fraud and corruption prevention policy outlines clearly the whistleblower protection. But what are the legislative amendments that are required to ensure that the staff, the healthcare workers, and also the patients can report corruption freely without fear of the reprisal? And the second question, what are the legal support that is needed to strengthen Queen Elizabeth Central Hospital Institutional Integrity Committee so that cases that have been forwarded to SCP are concluded more swiftly? I also wanted to understand on those ones. Thank you very much, Chair. I submit.
Thank you very much. We go to Mwanza West.
Thank you, Chair. My contribution goes to Chora District Hospital and Chiladzulu. And it's unfortunate to learn that you learned about corruption from the media. Because for them to make that investigation, it meant they were tipped that these things are going on. And from the presentation that we heard from Queen Elizabeth and is it KCH, they echoed to say, can your committee engage with media so that we work together, we help each other to end these things? And I just want to know, now that the media has brought to your attention that these things are happening, what are you doing now to end this? Because if you didn't hear about it before, I don't know how long you've been there, but it's either your ombudsman isn't doing the right job or the staff is comfortable with it. And specifically to Chora District Hospital, you acknowledged that the patients are being seen like 4 to 5 patients in one room. You acknowledged of that. Are you aware that the patients have the right to privacy? What are you going to do about that? Because I know Chora District Hospital, it's not that big as you're saying. Yeah, it's not that big, but at least it's much better than other district hospitals. How are you going to deal with it? Because construction is a long term. Now in the short term, what are you going to do about it? Because some patients, believe you me, they are not helped comprehensively. Because even me, if I'm sick, I can disclose all the information in the presence of other 4 or 5 patients. It can't work. It means I will just say the problem that I'm comfortable with, and I take the other one home, and you see that these patients will come back later with complications. I think let me stop there for now.
Thank you very much. Mwanza West, we go to Doampudzo.
Thank you, Chair. My question is basically on the Kamu's Central Hospital. It's something to deal with law reform. You did speak a lot in terms of administrative steps that you are taking in dealing with corruption and dealing with other security issues. So the question is regarding with the, you recommended stiffer penalties for both service providers and users who are involved in corruption. But just wanted to know what specific legislative changes should Parliament prioritize to close those loopholes and strengthen the deterrence of similar issues. In addition, also, if you have some suggestions as well in terms of what legal support you may require to strengthen the procurement oversight. We are talking of corruption cutting across, including even the procurement departments and all that. What legal support you may want, you would want for the Parliament to help with the procurement oversight and the inflated prices that usually where we have favoritism in the medical supply contracts. I think that's the question that I have.
Thank you very much, the people of Udowampodzo. We conclude this round with the people of Nkhotakota and Nkula. Are you ready?
I'm always ready.
Right.
Thank you so much, Chair. Much of what I wanted to say has already been said by Honorable Mwanza West. However, just to put an echo, Chiradzulu and Tiolo, I think you've done very well on step number 2, but you skipped step number 1. Because when you learned from a social media platform or a media platform that you may not like, because it's in human nature not to like anyone or anything, any grouping that is bad-mouthing what you are doing. But because this is not a personal thing, I thought the first thing for you was to make sure that you clear the skepticism that came with the news that you just heard from the report. Because there is no way you can go on to print t-shirts that we want this place to be corruption free when you are not sure the degree of the corruption. Because you didn't tell us if you made any strides to know the degree of the corruption at the place. The only thing you did is to start putting in place structures to stop or eradicate or maybe minimize the corruption that you are not sure if it's there or how much it is. So I would suggest that you go back to your drawing board and dive deep into it so that there is some realism, ground truthing. It is very important for you than to take 3-4 steps when the most important step is to know whether it's there and how much is it. Thank you so much.
Thank you very much, the people of Nkhotakota and Nkula, for the observations and comments on Tiolo and Chiradzulu. So Mr. FM had a fracture, went to Kamu Central Hospital, and then met the doctor there. 8,000 was demanded, but he chose to report to the ombudsman. The case was investigated, and then the officer involved accepted. Action taken, disciplinary measures. You haven't told this committee what disciplinary measures did you take, Bwana DG. And then Chitipa Nkatabe North highlighted the patient's rights. Are they being told about which services are free or not? And then there was also a case at the Queens, where a patient came for a tooth extraction, and this was reported by the media. And this patient stayed for 3 days, according to the media report, without any medical assistance until the media personnel gave them 10,000. And you have just told us that it is not in the jurisdiction of the central hospitals to handle such cases. What is the relationship between the central hospitals and the Association of Patients Welfare? We had Patients Community Welfare Association of Malawi yesterday. Do you have any working relationship? And then there's also another big issue. Our budget, fiscal year 2026 to 2027, health sector budget 9.3 of the total national budget. Donors are withdrawing. It means the health sector budget is being compromised. The SH has told us here that 40% of the health sector budget is being used by the foreigners because they come here for the free medical care services. But as a country, we are pushing for reforms, health financing reforms, to generate resources that will be channeled or injected in the health sector. The same resources that will be used by the foreigners. What should we do as a country? Because as a committee, we are pushing for these health financing reforms to generate resources for the health sector, but the same resources will be used by the foreigners. What should we do? We start with KCH. I hope you took note of your questions. Right.
Thank you so much, Honorable Chair, Honorable members, SH and colleagues. So I'm responding Nkata Bay North first. Asked me about correlation between staff low wages and theft, which is a very valid question. So first of all, we haven't done any analysis. No studies have been done at KCH, but if you read a UNDP report looking at country cases in various countries in the region, published, it was written by Professor Gillian Cora. The title is Fighting Corruption in Health Sector. They found out that low wages and salary stagnation in health sector are directly correlated with increase in theft, absenteeism, and corruption. So if you do this literature review, you'll be able to, we cannot reinvent the wheel. If these studies are done elsewhere in settings that are similar to ours, we would rather implement than to start reinventing the wheel, which will take some time. What are you doing about corruption? As you have observed, there are a number of things that have to be done depending on what type of corruption. And we have outlined issues. There are some systems some theft that is happening as a result of weaker systems. That's why almost everybody has brought in the issue of digitalization and stricter inventory management, improvement in supply chain from entry point to exit. Putting in infrastructure such as infrastructure that will help in terms of security and also protect these commodities. These are cut across and they are being done in various facilities, including KCH, as you have heard from Zuzu, Queens, and other district hospitals. Now, legislative changes, proposition. So on legislative changes proposition, what we would like you to help us with, we have observed that some of the cases that are in court are not fast-tracked. There are cases that have stagnated in court for the cases that date back as 2023. They haven't been done in court. This gives, it people out there think we're not serious about this, and the perpetrators think they can continue with their activities wherever they are because their cases have stagnated in court. Stricter bail and sentencing, push Ministry of Justice. I know Minister of Justice at some point tried to look at such cases if they could be non-bailable. If someone steals medicines, it should be non-bailable. Don't give them fines. These people have got money. They will pay and get away with their crimes. Mr. FM, report to Ombudsman, action, disciplinary action. So this case must be from Integrity Committee. So they have got SOPs, as I said, and 2 hours on how they deal with some of these issues. And in this case, that means this case was pushed back to the system, and we followed the MPSR and HR protocols. That means warning, second warning, then dismissal. As I said, these are some of the bottlenecks that we have to make sure we resolve, because then it means these perpetrators might commit another crime knowing this, the judgment and orders differ.
So he was just warned?
In this case, was warned, yes. Medical supplies contracts. On issues of medical supplies and contracts, now we have a system, the electronic procurement system, which we're still learning. I think if you have studied this system that we're using, is being piloted in central hospitals, you understand that it would be very difficult to go other ways in the procurement system. Thank you so much.
Thank you very much. We go to Cholo and Chirazulo. We had questions from Mwanza West. We start with Cholo.
Thank you very much, Chair, for the 2 questions from Mwanza West and the Nkodakota Nkula. The first one is related to communication vis-a-vis knowledge of corruption. Chair, we have the general knowledge of corruption, which is happening across a number of sectors. But we need to have validated information, actual information related to Cholo District Council. Currently, no one has come forward with evidence to say, this is what I have experienced. You have noted, Chair, that the case studies which we have shown today, they are related to the third part, the referral system. They refer it for POP, they refer it for a private, whereby they are paying their money. We have a responsibility, Chair, from this meeting to go beyond what we are seeing so that we can see the relationship between the people who are working in the hospital and the owners of the private clinics. In that way, we'll be able to establish something. So, Chair, is an assignment, and we are going to do it. Additionally, Chair, on the privacy, each and every intervention, Chair, has aftermath, either negative or positive. The putting together of 5 patients in one room is as a result of reducing waiting time of patients at a queue. However, we have noted that as we are sorting the problem of waiting time, we are creating the challenge of privacy. This is a serious challenge. This is the problem, but we are here to solve it. One way of doing it, we have engaged our partner. We need to mention, because they're doing a good job, ECPAF, who managed to petition the ART room so that people should be treated separately. More than this, we are further requesting them to go to under 5 clinic. At least we passion it so that we should have not 5 people in one room. So this one, Chair, is an assignment to the District Council. And be assured that we're going to do it with agency. I submit, Chair. Thank you.
Thank you very much. So the people of Mwanza West also spoke about the Office of Hospital Ombudsman. How much is it doing? Because apparently if you are telling us that you have the knowledge, it's just general knowledge. Everyone has knowledge about corruption, but this is specifically to do with Cholo.
Thank you very much, Chair. It's true. The question from Mwanza West related to the law and responsibility of the Office of Ombudsman. The Office of Ombudsman is doing a great job. All the 6 cases which we have reported here, Chair, are recorded in this office. However, there is no direct case which has been recorded in relation to corruption. Most of the cases, Chair, are related to servicing delivery. I submit, Chair.
Thank you very much. Chiradzulo.
Thank you, Chair. Indeed, as Chiradzulo, we learned about these corruption allegations through the social media. Apparently, the reporter who wrote the story just said someone blew the whistle about the acts of corruption happening at the district hospital. There's a saying that goes, there's no smoke without fire. I think that's what we were following, saying maybe something cannot just come from the blues. Chair, I want to concur with the observation made by the honorable member from Doha that as a district, we were really supposed to reach out to the reporter in order to find out the truth about these allegations. So we are saying that we'll do that. We'll go back to the drawing board instead of just saying, yes, the wrong is with us without going to the benchmark. But we were doing this not to show like we are frightening the reporter. Why did you write? So we have learned that we need to be doing that as soon as we hear allegations concerning our district. Thank you, Chair.
Thank you very much. We go to Queens. We had questions from Chitipa North.
Chair.
We had 2 questions from Chitipa North. Do you want the people of Chitipa North to repeat themselves? To repeat the questions?
Yes, Chair.
Please.
Thank you very
much. The people of Chitipa North, please switch off your mic. And Chiradzulo, District Council, switch off your mic, please.
Thank you so much, Chair, for granting again the people of Chitipa North constituency an opportunity to ask 2 questions to the Queen's Elizabeth Central Hospital, the DG. The first question is, he highlighted in the presentation that there's still more the staff and also patients who are still afraid to report corruption issues. So the question is, your fraud and corruption prevention policy clearly outlines the whistleblower protection. So what are the legislative amendments that are required to ensure that staff and patients can report corruption without fear of reprisal? Meaning from our law enforcement or law reform, what is it that you require legislative amendments that need to be included? And the second one is, what legal support is needed to strengthen Queen's Central Hospital Institutional Integrity Committee so that cases that have been forwarded to SCB are concluded more swiftly? Thank you very much, Chair. I submit.
Thank you very much. And the Chair added the case. I think you remember the question. Thank you very much. You can take it up.
Thank you very much, Chair, and thank you, the people of Chitipa. For the first part, with whistleblowers, the policy has guidelines, and it is clearly stated that whistleblowers will be protected. But as we've heard even from our friends from Zuzu, sometimes people do not trust the system, but the more the system is operating, we're sure that and the more sensitization we are doing to the people to reassure them that they will be protected, we believe that this will happen. So when we are doing our sensitization meetings, we did show some images where we are having meetings in the different departments, and we are telling them that message that the law protects you, so if you see anything, please protect us. On the legal backing, for the Anti-Corruption Bureau, we would ask, I think, our Secretary for Health to assist with notifying the Anti-Corruption Bureau that they should speed up the cases so that they should be concluded. We did report of 2 cases which were reported to Anti-Corruption Bureau up to this time. They have not been concluded yet. And also, if probably they could give us clear timelines that when we report, how soon should we expect the case to be concluded. I think that will help us and it will encourage people to report. Of course, even at the ACB, they have also been complaining of issues of finances and availability of staff, so that they may not have enough capacity to handle the cases that are being presented before them. Chair, for your question, you did mention about the patient association welfare. As central hospitals, we are a bit challenged. I mean, we did have our management meeting on Monday, and we're discussing what is our catchment area. Central hospitals, we are supposed to offer tertiary care, which is specialized care, and our patients come from the districts, so they're supposed to be referred from district hospitals. So it's difficult to organize them so that they can give us feedback. When they're in the ward, yes, they've got the chairman and people like that, but for an association to work, that's a bit of a problem. So I think we can learn and teach each other, I think, how best we can do that, but we are struggling to see, because it was also our wish that to say, how best can we reach to our stakeholders, to our catchment area, but that was a bit of a problem because of the way the hospitals are designed. If you may allow me to also address the issue Katabe North raised about the connection between lower wages and shortage of staff. On lower wages, I mean, DG KCH did mention of the study, but if we can debate, I mean, we know corruption is as old as the world is, and rich people also engage in corruption. So raising people's salaries in itself does not mean that we can curb corruption. That's why we are looking at integrity and teaching our staff, educating our people. When people are educated, when people have integrity, even if they don't have anything, even if you don't have transport money to take you home, you are not going to take fraudulently. I think that is what we are doing, and that is what our committee is trying to do. And we are seeing some results already, that the more we are educating the people, things are improving. You also did mention on the issue of whether we are indicating which services are free or not. For the case of Queens, we do have our charter, which is displayed at a very open place, but unfortunately, I don't think it does state what patients can pay for and what not, so we have taken note of that. We will include that on our service charter so that we can show what people can pay or not. The direction that we are taking is the same. If we talk about issue of staff shortages, what we have observed is, as a hospital, we are funded to provide tertiary care. If you talk to most of the departments, they are saying that about 60% of the patients that we are seeing is either primary care or secondary care. Now, the House should understand, I mean, the committee should understand that Blantyre District does not have a district hospital. So patients who should have been managed by the district hospital, they end up coming to Queen Elizabeth Central Hospital. But our funding does not reflect that. So that's the challenge that we have. If I give you the figures, like for doctors, we've got a 60% shortage of doctors, but we're also seeing 60% more patients who should have been seen by the district hospital at a lower level. So that creates problems in a way on how best we will manage. And I think I'll give you an example of in our emergency unit. Our emergency unit handles about 250 patients every day. Of those patients, 30 to 40 patients are patients who should be in that emergency unit. The rest can be handled either at primary care level or at a district hospital. For those 250 patients, from our calculations, we need 12 clinicians, 12 doctors, 12 clinical officers to attend to those patients. But because of the shortages we have, in the best case scenario, we have 5. So you have got 5 patients, 5 doctors who should take care of patients who should have been seen by 12 doctors. That creates problems. So yes, if you come to our emergency unit, there are people who are staying in the unit for 48 hours when the process has not been finished. Why? Because there are no doctors. And then that will help me to answer, can shortage of staff encourage corruption? Yes, it does. Because you come there, you're waiting for 48 hours, somebody offers you, no, if you give me something, you'll be assisted quickly. People will take that option. So according to our figures at Queens, we need 203 more doctors. And I'm telling everyone, if you give us 203 doctors at Queens, the doctors will be looking for patients to take care of, not patients looking for doctors. So that is the message that we're spreading. If we have enough staff, most of these incidents, there'll still be, yes, but most of these incidents will go down. But the demand is high and we don't have enough workforce. I think I've addressed the question.
Thank you very much. Queens need 203 medical doctors. The SH is here. I will let you continue taking your notes, SH. We got the people of Desert Zaranyama. From the people of Desert Zaranyama, we go to Dowa West. From Dowa West, we go to Blantyre Southeast. From Blantyre Southeast, we go to supplementary from the people of Katabe North, and then supplementary from Mwanza West. We finish off this round with a question from the people of Chitipa South. In that order, please. Desert Zaranyama, indicate where the question is going to, please. Would you please use your mic?
You have missed Ncheu Central East to ask Kamuzu Central Hospital a question.
We start with the people, the wise people of Ncheu Central East to ask the Kamuzu Central Hospital a question.
Thank you, Chair, for recognizing the people of Ncheu Central East to ask Kamuzu Central Hospital. First of all, let me say cases of extortion and denial of emergency care show inefficiencies in triage and emergency response. What reforms in patient flows, HR deployment, and supervision are needed to prevent such abuses? And secondly, it's not a question, it's just a comment or a tip. Are you aware that most of the patients you see in OPDs, I can say, those clients, they're not actual clients, some of them, they're bogus patients. I heard the director of Queens complaining of bogus doctors, but you have to realize that you have also bogus patients in your hospitals. What are these bogus patients? Most of these bogus patients, 99.5% are those guardians. They do rotate every day when they're in the hospital, going to the prescribers. When today they've been prescribed, they will tear that paper, and tomorrow they go again for the prescriber. They can do that if they've been in the hospital for 1 month, attending to their patients. They'll go again to the prescribers for 30 days again. So should take note of that. And I heard the director of Queens that he has set aside, techniques to control the bogus doctors. The way you have done that, you need to do the same with the bogus patients in your hospitals. You may wonder, I'm a member of parliament, why am I able to know this? I'm also a medical practitioner. I've been working in the government hospitals, the charity hospitals. I know these things that are really happening. And it's evidence-based. Thank you very much.
Thank you very much. The people of Unchew Central East, he has over 30 years experience in medical field. So he's speaking from the point of knowledge. We go to the people of Dedza Zaranyama.
Thank you, Chair, for recognizing the people of Dedza Zaranyama to ask a question. My question goes to Queens. Dr. Kasungu District Hospital generated about 167 million through its paying wards in 5 months. Given Queens' largest patient volume and referral laws, what revenue potential exists if Queens had adopted, or if Queens can adopt a similar model? And what safeguards would be needed to ensure equity, prevent of corruption, as well as guarantee that funds are transparently reinvested into patient care, targeting the most vulnerable people? Chair, I submit. Thank you.
Thank you very much for that beautiful question. So it is going to the Queens. Specifically, the question is talking about health financing. We are not discussing health financing, but you may choose to take that question for the benefit of the Malawians who are watching us here. We go to the people of Umanza West.
Thank you so much, Chair. I just want to supplement to Choro District Hospital. You have committed to this committee that you're going to take this matter as an emergency. So I just wanted to know, how long should we wait to hear from you? Give us a time frame, because since this investigation was made, it has been months now, no change. Now that you have committed to us that we are going to see improvement, how long should we wait to hear from you that things are now in order? Because I'm weighing the risk of long waiting time to the risk of depriving somebody of privacy. It is more harmful to deprive somebody of privacy than to let them wait a bit. How long should we wait for you? Thank you.
Thank you very much. We go to the people of Doha West.
Thank you so much, Chair, for recognizing the people of Doha West. My question, I have 2 questions. Those questions goes to Queen Elizabeth Central Hospital. In your explanation, you said security officers were caught stealing theater materials and jails. What reforms in hospital access control and human resource management are being implemented to prevent rescuers? Another question, what systemic gaps in patient flow and triage allow clerks and guards to extort patients? How is Queen Elizabeth Central Hospital addressing these inefficiencies to ensure equal access? I submit, Chair.
Thank you very much, the people of Doha West. Just to inform you, honorable members, that we also have Nzu Central Hospital in our midst. In case you have forgotten, we go to the people of Blantyre Southeast.
Thank you, Chair. I think for the people of Nzuzu, I think they mentioned about the mismanagement during the COVID and illegal bypass fees collection, which were documented, and the cases that I think they concluded and submitted. And they talked about the gaps that were remaining, ensuring that the perpetrators face sanctions from ACB, police, and regulatory councils. And I think they talked about 9 complainants, reported fake government receipts being used at the facility. The question is, how did you manage to ensure accountability for the staff involved, and what reforms are needed? You know, the focus It's like we are like repeating the questions, but what you should understand is that you are coming from your district councils and the hospitals themselves. I think you have drawn allowances as you are coming. You have even put a lot of fuel in your tanks as you are coming here. But what you should understand is the time you are coming here, you are giving us the reports well articulated, but the reports, I think you had your homework because you knew that you are coming to Parliament. So the time you had the input that you are putting in the reports, you find out that some of them you have added some sugar in it so that you don't have problems here at Parliament. But what you should know is that the people are watching out there, people are watching. And some of your relatives are suffering in the hospitals. So I think these are the things that you need to be serious, because even if we ask you about the reforms and what you are going to do, this is what you need to do, because you need to assure this House, assure this committee that these things you are going to do. And if you have the gaps, it is time for you to tell the Parliament that we have these gaps and things are not working, so that the country can try to help you so that things can be solved. We know that you can solve alone, but be open enough to tell the Parliament through this committee the gaps that you have. Thank you.
Thank you very much, the people of Blantyre Southeast. The message going directly to Nzu Central Hospital. Supplementary from the people of Jiripa South. Have you withdrawn? Oh, Nkatabe North.
Yeah. Thank you, Chair, for a supplementary question. I've got general question to SH. According to all these things which we are discussing here about bribery, corruptions, where are we faring? Where are we faring as Malawian, also as the country? Lastly, the supplementary, I think from Queens, I think he has elaborated that the shortage of doctors about 203. You are the policy holder. What are you doing? Thank you.
Thank you very much, Nkatabe North, for those two supplementary questions going to Queens and SH. So SH, I will still keep you, continue taking notes. There also a mention from Nzuzu Central Hospital about uncoordinated recruitment, where someone gets fired elsewhere because of malpractices there, he goes elsewhere, he gets employed again. And this can also be fueling corrupt practices by individuals being adopted back into the system. Take note of that, that issue again. So we start with Ncheu Central East. There was a question from the people of Ncheu Central East going to Kamuzu Central Hospital. And then, again, there was a tip, Bona DJ. You can take it up.
Thank you so much, my honorable MP.
Point of order.
Yes, what is out of order?
You have missed me, Chair.
Okay, what is your question?
Thank you so much, Honorable Chairperson, for yielding the floor to the people of Jiripa South. The people of Jiripa South want to draw their attention to Rikoma District Council, particularly referring to the case of a driver who got around 55,000 kwacha from the guardian of a patient who was referred to Mzu Central Hospital. And of course, the manner in which this case was disposed. As a former Ministry of Health employee myself, imagining that I'm in the pharmacy dispensing medicines, because I'm a pharmacist. Okay, so I'm saying, as a former employee of the Ministry of Health, I'm trying to imagine a situation where I am the pharmacy and I'm dispensing medicines, and then I'm demanding 50,000 kwacha from a patient for me to dispense medicines, or any nurse or clinical officer demanding 50,000 kwacha from a patient to provide treatment, that matter, in my view, wouldn't be small as the way the people at Rikoma handled it. The matter would be going to SCB. By the way, we are discussing corruption in health facilities. It's not that all health workers are corrupt. We have a few bad apples who are denting the image. So my thinking is, this one is not a health worker, but it's a driver. But getting 55,000 kwacha, and then the only thing you can give is a warning. I'm scared if that is the route should be taken. Because the same amount of money demanded by a doctor, the doctor will be in the papers. So I don't think that is the best way of handling corruption, by just giving a warning. I submit, Chair.
What is your question? Was it a comment?
My question is, do they believe that the punishment they gave is daring enough? Thank you so much.
Thank you very much. We go back to DG Kamu Central Hospital to take up your questions.
Thank you so much, Honorable Chair, honorable members of the House and SECH and the team. I'm responding to our Member of Parliament. I'm from Cheo, by the way. Don't ask me too difficult questions. Anyway, first of all, let me acknowledge what you have said and the insights you have given us as healthcare workers, that they are also bogus patients with your experience. I think if there is one thing that we have benefited also in this meeting, is also to go back and do the assignment looking for bogus patients and how to crack them down. I know that won't be easier, but I think that's one way on how we are losing most of our medicines. On issues of HR supervision, KSH has introduced MBWA, management by walking. As simple as it sounds, but it's helping us deal with a lot of issues when it comes to manning various departments and areas such as casualty, OPDs. So we are doing this every day. For this month, we did it from, we have a plan, we had a plan to do it the whole month, each and every day. And the team has been committed to doing that and has reviewed a lot of things. We are, with the issues that we have found on our management by walking, we feel we need to develop a tool and start a standardized tool on how we can periodically be doing this activity, because it's revealing things on day-to-day basis that we did not know. So we need to intensify supervision in all areas where we have HR within the hospital. There are a number of issues. If you visit our casualty, you understand some of the issues that we're facing. You'll find it very overcrowded with very few medical officers, clinicians, and nurses. And sometimes also, you might not find anyone. But with this supervision, at least people are able to understand that their senior management is on the ground, walking around, not only policing them, but also finding out what other issues or problems are they having and trying to address them acutely so that our presence is felt. Thank you so much.
Thank you very much. We go to Cholo District Council. Give us the time frame. You have already responded to some of the issues. The people of Mwanza West want a time frame on the action that you need to take.
Thank you very much, Honorable Chair, for the supplementary questions from Mwanza West. I'm aware that the frequency of this question from Mwanza West validates the seriousness of the issue. With this, therefore, Chair, we must appreciate that strategies are in categories. Long-term strategy, we need an extension of the hospital, or we should have a functional community district hospital, which should offload some of the patients at the district hospital. But we need the short-term strategy is petitioning. In ART, it's done. We need to go to under 5 clinic and the other areas where people are treated, are taken care of in a number of 5. With this, therefore, Honorable Chair, let me confirm here that every Monday is a management meeting in Cholo in the morning and in the afternoon at the hospital. This issue will be taken care of and discussed holistically, and scenarios be taken and suggested solution will be done. Chair, with this, therefore, allow Cholo District Council to submit our action plan by Wednesday next week so that you should be aware of what we are going to do. I submit, Chair, thank you.
Thank you very much. That is very commendable from the Cholo District Council. We go to the Queens. We have 2 questions from Doha West. No, I know. You have your question, and most of your questions were just comments, actually, from the people of Blantyre Southeast, where they were giving you directions and praises on what you have done as in Zuzu Central Hospital. But we go to Queens Central Hospital. 2 questions from the people of Doha West.
Thank you very much, Chair. I made a lot of notes, so I'm not sure which one was Doha West and Chair, I made a lot of
Doha
notes.
West, would you be kind enough to repeat the questions?
No, Chair, I was just wondering, since I made lots of notes, can I just address those ones? Maybe
Yeah, please, sure.
Thank you very much. I think I should take cognizance of the question about the revenue. We were given a good example from Kasungu, where they raised 100 and something million. In the last financial year, Queen Elizabeth Central Hospital, we raised 587 million Malawi kwacha from our revenue generating activities. We are planning to push that to 1 billion in this financial year and even more. How we are using that money, I always say that healthcare will never be adequately funded. I think even in the rich countries, they are struggling to fund healthcare because healthcare is expensive. So despite all the support that we get from government, we are still using most of our revenue generated within the hospitals to support our patient care. A very good example, at the beginning of this year, we had a big problem with our gas plant. We had to transport oxygen from Lilong. We were buying oxygen from Waira, taking it down to Blantyre. 3 trips every day on a big 10-ton truck. And we are using money from our revenue to buy fuel for that, because that was not budgeted in our budget. The staff that were going to do the work. So then, due to funding delays, there are always emergencies within the hospital. Maybe a bulb is not working somewhere, so we use our revenue funds to sort out those problems. And it is making a very big difference in the care that we are giving to our patients. There was a question of, I think, bogus patients and how we can address that. What we are trying to do at Queen Elizabeth Central Hospital, we did say that we are planning to give controlled access to the hospital. The problem we have at Queen's is overcrowding. We've got a lot of staff, and we have about at least 1,000 patients on the ground all the time. Each one of these has at least one guardian. That's like 2,000 or 3,000 people within the hospital. This creates a lot of problems. So the plan that we have is, once we get identity cards for our staff, we are also planning to have to enforce that each patient should have only one guardian in the hospital. And we are also going to give them identity cards so that we know who is a guardian, we know who is a practitioner, who is a health worker. Then the other people who just come in, we hope with that we're able to shield them out. Because people are just coming in, and we do have a big challenge even with street kids. Street kids are invading Queens and causing havoc within the hospital itself. That is happening. So we think if we have controlled access, probably we will manage to control some of those problems. On the issue of payments, we are trying our best to make sure that we realign the services that we give. Those of you who are on social media, 2-3 months ago, we did issue a circular that patients who are coming for tertiary services, those are the ones that are funded for, those services are free. But those people who choose to come and get secondary services or primary care services at a tertiary care center, then they have to pay for that. Otherwise, they need to go to their respective district councils, and then they should be officially referred to our hospital. If they are not referred, then they pay like the bypass fee, which is what Zuzu has also been talking about. We have delayed implementing that a little bit because we want to have proper structures in place. We have just instituted a paying system through Mpamba, which is an electronic paying system. We are also consulting the friends with Airtel Money to see how. What we want is that there should be no money exchanging hands. If people have to pay, they pay through Mpamba. Then we have identified heads of departments and other leaders in the department so that when the payment has been made, then somebody in the department will get a notification that yes, the payment has gone through, and then the services can be rendered. So we think with that, we will reduce the chances of money exchanging hands, because our thinking is, even if we have a paying system, but if there's cash floating around, then we may not address this problem. So we are putting notices around that people should know that the only way to pay is either they go to the accounts, or if they need to pay for a service, then they have to do it electronically at numbers which are going to be displayed. Messages have already gone out. I'm sure some of you honorable members might have received messages of this, that we are going electronic in our paying systems. I should thank the honorable member for Blantyre Southeast for your comments. We really appreciate that it is your wish as a committee to help us work out these things better. We are facing a lot of challenges, and I think this interaction, we have taken a lot of notes on how best, on other avenues we can use to address the challenges that we are meeting. With that, I also invite you, honorable member, to visit us so that you can share more of your wisdom, because you are our neighbor, I'm sure. Thank you very much.
Thank you very much. We go to Mzuzu Central Hospital.
Thank you, Chair. To the honorable member, it was not my intention to display lack of seriousness. I had really consulted the team that I'm with, and with me, we have our chief accountant. I should also let the team know Mzuzu Central Hospital struggles to retain or to have senior officers report and work in the northern region. At the time of this COVID-19 audit, we did not have a chief accountant. However, this accountant who had swindled funds for fuel for COVID was due to internal routine audit measures. That is how it was identified. And being above grade K, he was referred to his ministry line, appointment and disciplinary committee, and the case was also in court. For us, he was interdicted, and that is where it ended. We could not or do not have any powers to move further than that, apart from doing our routine follow-ups. And so during the COVID, was only that fuel part. And also just to inform the House, when it came to audits for Mzuzu Central Hospital COVID-19 funds, we were one of the best performing facilities. On the fees, in terms of the bypass fees, we have an extreme shortages of accounting personnel. There's been a lot of transfer outs, there's been a lot of retirement. Unfortunately, there's a freeze on recruitment. At the moment, we have a chief accountant as the highest grade. To be honest, he's the first chief accountant who has reported and stayed in the facility. Majority come report and then they're transferred out. And we only have 2 accountants. Those are the 3 highest grades we have from Mzuzu Central Hospital. When it comes to collection of bypass fee, we made sure that the bypass fee should only be collected by accounts personnel in strategic places. But like I said, during the night, we have extreme shortages. So maternity and emergency department, we just use a book. And I'd also said we would love it if the health centers around us should be upgraded so that we reduce the need of collection of the bypass fee. At the same time, trying to digitalize so that the banks do the collections, and maybe during the weekends and the night, that's when the account personnel can then come and do the collection of the bypass fee. Thank you.
Thank you very much. We have Queens. You want to say something?
I think I forgot one important question, which is probably the one that was asked about how on earth we allow security guards to infiltrate our system and start even collecting money for patients. I don't think I addressed that. As I said, Queens is a very big place, and what we're afraid about the network is, I think it's a system, as we said. So the guards know which 2 or 3 bad apples would accept the money so that they can, so basically the guards act as recruiters. So they recruit. We have heard of a case where maybe 15,000 was collected, then the guard took his bit, then they gave to another bit. But this money was actually money for lunch for this patient. And then the patient had was very hungry and was complaining to the team, and one of the people who received the money had to give the money back to the patient so that they can go and have lunch. So we are facing deep problems. We are trying our best. I mean, we are getting this information because we are working on them. People are reporting that this is what is happening. We also had an issue, I think, in our pharmacy, where because it's the same guards in the pharmacy, then they knew which patient attendants are coming to collect drugs and things. So now we put a system that when a guard is allocated at a station, they should stay there only for 3 days. After that, they should be moved to another station so that they don't get used to the system. Of course, when they hand over to each other, we don't know what they do. There are the issues of training. Another challenge that we are facing is that I think the guards that we are using, they are contracted. So what we have noted is when they have not been paid in time, we have chaos. Sometimes they don't come to work or they start doing these other things. And we know the way Treasury is funding us at times there are delays. So when there are those delays, we do have a lot of problems. We don't know whether we should go back to the time that we are having our own guards, but we have those challenges because they are contracted. That is also giving us issues. Thank you very much, Chair.
Thank you very much. The driver in Nkoma was just given a warning for demanding 55,000 from the patient. Was that warning deterring enough?
Thank you, Chair, and the whole House. Likoma does not trivialize the offense. To us, it was like the driver got a blessing from his senior to ask for support from the guardians because at that particular time we didn't have fuel, but we still needed to take the patient to Zuzu, and the guardian obliged. But what the guardians complained was that he didn't fuel the vehicle as they were going to Zuzu Central. So our warning was that he didn't act transparently. He was supposed to have asked the guardian to pay at the filling station other than him fueling the vehicle on his way back. Thank you, Chair.
And the senior officer, what did you do with him?
Honorable Chair and the whole House, the issues of referral are rather complex with us in districts, where sometimes we ask the patients to go on public transport. That's trying to ask them to contribute because maybe we are stranded. So the senior officer had to give that instruction just to see to it that the patient had reached the central hospital. So we didn't do anything to the senior officer
Thank you very much, honorable committee members. Take note of that, so it's normal sometimes that the patients are asked to contribute something on the transportation of their patients, or guardians are asked to do so. More questions, honorable members? It's 3 minutes to 2 o'clock and SCB is already here. Mwanza West, then we go to the people of Cheu Central East. Right, so we finish off with the people of the Cheu Central East.
Mine is not a question.
It's what?
Chair.
It's what?
A comment
okay.
About the Likoma issue. On the Likoma issue, in my case, I salute the driver who charged the patient 55,000 for the fuel. Just because this patient was from Mozambique, 1. 2, you have already said that you are having those problems. I salute that driver, he did very well. You don't need to punish him, that's my thinking. In these cases, we have seen that most of the patients, they are from Mozambique. I'm asking the Secretary for Health to involve, to ask to have high-power delegation, delegation from Malawi to Mozambique to discuss about these issues. As you are saying, there's a need for, funding the Ministry of Health, financing the Ministry of Health using our own resources. We don't need other people from outside the country to eat our money. Why should we do that? Secretary for Health, let's be serious with these issues. I've never heard people from Malawi going to Mozambique to be assisted. And I hope if people from Malawi, if they go to Mozambique to be assisted, they'll be chased. It's for sure. Because even if we go for other businesses in Mozambique, we are harassed. But people, they go from Mozambique coming to Malawi, we are very quiet, we are very polite, and up to the extent of consuming our resources because of people from Mozambique. Why should we continue doing that? Thank you, Bana SH. I hope you are going to see these things. Even the high-power delegation to go and meet the high-power delegation in Mozambique to discuss these issues. Thank you very much.
Thank you very much. The people of Cheu Central East, like I said, is a veteran in the medical field with over 30 years of experience. So he's speaking from the point of knowledge. But looking at our time here, I think we need to give chance to SH to respond to some of the issues. Some of these issues to do with policy, just like he is raising here. We are discussing health financing reforms. As a committee, we are pushing these reforms, but resources are being taken up by foreigners. Yet, just across the road, people in Cheu, Malawians in Cheu, may not be able to have the access of services in Mozambique. SH, what are you telling the committee? This report that we are discussing now, we are presenting it in July. What should be our takeaway points? Over to you, SH, and you may also wish to conclude after responding to these issues.
Thank you very much, Chair. If you may allow just a minute or two for our internal auditor, just to highlight a few things. There was a question from Katabe on, we have all this, why are we failing? Where are we failing? So maybe our internal auditor has hands-on experience on these issues.
Thank you so much, SH. Honorable Chair and honorable members, I think a lot has been discussed throughout our discussions, and it has come clear that there are a number of areas maybe which we need to point out, which maybe we need to put in more focus. I will not waste much of your time. I think we have heard from all those who have, commented on the issues that there are times we are doing our best as Minister of Health, but there are times when we have done our part, we give the issues maybe to other government departments or agents. For example, we do work hand in hand with the Malawi Police Service and also the judiciary. So this area is also one of the high-risk area, as already highlighted by the DG for Central Hospital. What we are experiencing on the ground is that normally we go there, but we find that maybe
the sentences which are given are not enough to deter people to, engage into these activities. You've heard one of us mentioning about the case of, a foreigner, a Kenyan, who has been sentenced. He was convicted, but with a fine of 800 kwacha. But if you look at the drugs which was possessed, there were a big chunk of drugs. And at the same time, if you look at the resources which are put in, into these, investigations, there's a lot of money. So we need to balance up to see we are spending as government from the other hand, and also from the other hand, we are letting go those people who are, involved in these malpractices. So, from our side as internal audit function, some call us drug theft investigation unit, we have contacted the office of the SH to also talk to those senior officers responsible for these departments. For example, the Inspector General and also the head of the judiciary, so that we take this issue seriously. We cannot agree here. If someone is caught with the pangolin, it's a serious case. People are, you know you are gone, you are arrested and you go to prison. But we wonder why healthy issues are not taken lightly. So we are working hand in hand so that we can address some of the issues which are happening. On the other hand, we have also put cases, in as much as these departments, they have work to do, but we also have to do good homework. That is preparation for the cases. Maybe you go with the, weak points. That's why maybe you find that maybe the system is failing maybe to give them the stiff punishment. So we have put in place a mechanism where we'll be doing what we call pre-trial cases before maybe we go for the actual case in the courts. So that we do away with all small issues or gaps, so that we achieve what we want. On the other hand, when we are done with the cases, the courts normally give, judgments in form of acquittal, and at times they are convicted. So when our colleagues, maybe they has been acquitted, I think the district councils or the central hospitals, they are supposed to take necessary actions, as you have already asked, and they have responded that we need to make sure that we address these issues. If they need to give them warnings, they are supposed to be given warnings, so that maybe the warnings, when they accumulate, then it will be fit for them to be dismissed from the service. On the other hand, I've talked of, conviction. Convictions are in three forms. We are given fines, and at times they are given suspended sentences and also custodial sentences. So when they are given fines, we find that when they go back to our workplaces, nothing much is being done, but we are working hand in hand with our colleagues from the human resources from the district councils and also central hospital to make sure that we fast track the process. When we get the judgments, these people should face the regulations which were put in place to guide those who have been convicted in the public service. On top of that, I think they have talked about issues to do with internal controls. Let me quickly point out, they are weak, especially at the dispensing point where we don't have, a strong system which track which patients have received the drugs. So currently, I think the ministry is working on the issues to digitize the whole process. And at the same time, we are working with our colleagues from the district councils, the internal auditors, so that they should maybe also be auditing our hospitals, especially where we have high risk areas. The high risk areas are where we are dispensing the drugs. I know we don't have the stock cards in our wards. If you have them, they are not up to date. But these are the issues which internal auditors from the councils should be able now to check whether we are following these, internal controls. Finally, let me also talk of awareness. We all have the responsibility to, put the message to our masses so that they know exactly what they're supposed to do. We can agree here, we do find drugs in our local markets, selling in open markets. So if people, they don't know the
dangers of, taking drugs from, places where they are not well kept. It's another issue which will also give pressure to the hospitals, because once they take those drugs, they will definitely have problems and come back to the hospital. So I'm also urging our honorable members, when you are deliberating with our colleagues, when you are meeting us in our respective constituencies, let's talk about these issues. People have to know. People have to, make decisions based on informed information. I think from that note, let me stop there and maybe give back to the SH to close as you give the floor to him. Thank you, Chair.
Thank you very much, Chair, for calling us to this meeting. When we, our recent visit outside, looked at the various sectors and the risk for corruption in the sectors. So the first sector that was highlighted in that visit was the finance sector. That is very high risk for corruption. The second sector was health. So health can, and is indeed internationally recognized as a potential area for corruption. So your calling us is not in vain, it is necessary. And there are various reasons that health sector is prone to corruption, especially around procurements. The procurements on medicines, the licensing system of medicines, and the honorable from Chitipa knows these things. The whole supply chain is a big area. And let me be clear, Chair, here, that once in a while, I really feel that those that are in the drug theft investigation unit need to be recognized in a special way, and they need to be protected. It's a cartel. People are putting in billions. I mean, the budget you put to medicines, the parliament here passed about 110 billion quite. Everyone is now wanting to get into that space. But do they have the requisite qualifications in terms of licensing and the processes that are required, safety and quality of those supplies? All the other supplies and equipment, high value equipment, CT scans, MRI scans that have to be procured, X-ray units, all those. Infrastructure in health is not as cheap as other sectors. And I do believe that that's probably the reason that some of members here are a little reluctant to use the CDF to get into health. But you will not win an election if you don't invest in health. Let me just warn you that if you don't invest in health, you will not win the election. So please invest in health. You win it. I mean, the honorable member from Nchewu knows this. Yes, he does. He will tell you the whole story about his constituency. So yes, I mean, invest in health and you win the election. But it is a highly risky space for corruption. There have been efforts. The commitment to fight corruption within the ministry is at the topmost. In fact, we are guided by the leadership, both the minister and the president. And I'm saying this because there have been times where OPC has delegated other staff intelligence to support us on ramping up these issues. So when you look at somebody has been caught stealing medicines, it's not just a coincidence. Someone is working underneath just to ensure that we really are at the bottom of it. So there's a system really that is working. Only yesterday, OPC, I was just checking here, has released a plan to help the ministry fight drug theft investigation. So that will be released, and Parliament, the committee is also included in that plan. So we're working as ministry to ensure that we are corrupt-free, especially that we do have a lot of development partners investing into the sector. Couple of things that I will need to reply to. I think the first thing that I would want to implore upon our chair is the national ID, and I'll bring that up. Let's get all Malawians registered. And let's not wait for the election year because it becomes politicized. If you start the campaign to register Malawians in the year of the election, people will shun it. They'll give all kinds of excuses to that. So please, if we can do it when all is quiet, silent, and people know that it is for good intentions to identify those 45% additional people that are coming from outside, whether from our borders, better. Of course, the international conventions that we signed do allow emergency care. We mentioned it, Honorable. Refugees are allowed. So there are some sectors that will still be allowed by international conventions to access care. So the national ID, and whether there's no national ID, the number, and that when children are coming to the hospital, the mother in the health passport book, there should be the number of the child. And then that can help us track most of our products. Then the second thing, Chair, and that should be all of us, including Parliament. And maybe we may need to really allocate for long term, if we really want to do good to this country, long term, beyond our term of office, national IDs. Then the next one that I would want to bring up, Chair, is financing. The central hospitals have mentioned how they're collecting their funds and how they're doing. They will have their hospital autonomy and they'll have a governance structure. Districts, Chair, are struggling. In fact, if there's one thing that gives me a headache, now are districts. Districts run ambulance services, central hospitals, not much. When the fuel increases are there, it's the districts that suffer. So if you go to all districts, I've visited a couple of them, already they're struggling when the fuel increase has gone up. So some of the services that would have been available, the referrals, the 55,000 and all those sort of things, I would really not like, I don't like it that ambulance services are only reserved for maternal child issues. Because there are also men, there are also older women that would need the ambulance service, but they don't get it because the ambulance is reserved for maternal cases. Because that's only, so if we really want to increase access to care, then we may really need, from council, need to understand the health sector is 24 hours. The health sector has to go to the village. The health sector has to do movements of patients, very vulnerable at that material time. So if we could look really at the funding for councils, because even when we tell them uniforms and they're stuck, they may not be able to implement some of the, I would want us to zoom into the budgets on health and then enforce, let me just mention this, enforce at council that as a ministry we indicated which budget lines should be ring-fenced. We did indicate there's a circular, but some other councils are not doing that. And then there's also allocation of resources once those resources are at council level. So I'm bringing it up here that all of us we come from the councils. Please, let's look and understand what's happening when monies are coming at council level and how they're being utilized at the council level. Where possible, Chair, audit systems at council should also go to our pharmacies. So it's also in your call to ask the auditor at council level, not only to look at money issues, but medicine issues. And if we need to train them, our team here is ready to train auditors at council level, because the work is just enormous for a single office to manage. So if we could also decentralize that monitoring at council level, then we could really start improving on our performances and protect our people. I mean, the issue is protect the staff, protect the patient. Second issue the third issue that I would like to bring to the House is service delays. Service delays, and we know that that can push corruption, like at immigration, like anywhere else. So if we delay on care and we are not able to decentralize care, then it can push. Zomba District Chair, the only X-ray system is at Zomba Central Hospital. So anyone in Zomba who gets an injury, if they need an X-ray, they have to go to Zomba Central. So you can actually see how easily Zomba Central Hospital can get overcrowded. And so the more we can decentralize that service to Domasi, and also your districts, do the mapping in your district on where can we decentralize those services. In terms of high-risk areas for corruption, we have radiology. So what we've noted, people that, because private sector doesn't have X-ray services. Most of the private small hospitals don't have X-ray services. The only place they go is send them to government facilities. The other area that is high risk, so ultrasound scan they don't have, X-ray they don't have, they can have a small lab. They can do full blood count. All right, but those are the two areas. And then of course pharmacy. Then the other area that there's a little bit high risk of corruption is surgery. Surgery. People want their mother, their whatever, to be done and not wait, not to be on the waiting list as a court case, right? So that's where you'll see that if you look at high risk, not that the other departments don't get to be corrupted, but in terms of what we've noted, in terms of high risk for service delivery, those are the areas. So decentralizing surgical care, decentralizing diagnostic services, and generally getting community hospitals would be very helpful, especially in urban facilities. So we'll be coming to your districts. We've been to some of the districts and they've already told us, please, let me just mention this. I know that people want to protect their constituencies, but sometimes the Director of Health, Social Services and the DC probably know a little bit of the mapping of the district. I can highlight one or two districts that we've gone to. I mean, if you go to Nsanje, Oceana, that's across the Shire. Because from Nsanje, the ambulance has to go to Chikwawa, to Tabwa, go to East Bank, down to Makanga, and then pick a patient. Move that whole, right. So the mapping, the council does know, and they can guide. And then you as politicians, you can work together and say what is the best place for a community hospital, where we can give theater space, we can give X-ray services where the risks are high, right? So let's decentralize, but let's do the mapping together with the politicians, especially with the CDF. We notice the issues of staff allocations. We do have, surprisingly, Chair, and Member of Parliament from Katabe, Honorable, I really was surprised when I came back to office. In 2019, Room P had 6 doctors. Right now, there are 2 or 3. I don't know where the other 3 are and why you couldn't replace them when they are already put on the payroll. I can't, by now, my expectation was, I was saying that Room P should have maybe 14, 15 doctors with an equivalent match of nurses, equivalent match. So I really, and against that, the payroll or the wage bill got like 3 times higher. So that's where it doesn't really make sense. It doesn't make sense that the wage bill goes up, then there's a lot of attrition, right? And no replacement. And so that really, so we've asked the Health Services Joint Fund, we'll get a consultant on HR. Chair, if this country has to move one big area we can make maybe 30, 40% efficiencies is human resource management. 30, 40% efficiencies is how we manage our human resource space. Not only in health, but big in health. And so we will be going out there. I've requested all district councils to provide the whole list of staff, whether they're at the health center. Because we've known that while we work with LASCOM, Local Government Service Commission, we also need to support them, that health, when they are allocating or changing staff, transferring staff, it is informed by density, population issues. So it shouldn't just be moving people anyhow without getting informed on what is the real space that we need to move to. So we need to move closer and work together closer with LASCOM, Local Government Service Commission. On issues that are also, which you didn't highlight, Chair, we would like to get and support us on centers of excellence. One area that is highly corruptible is external referrals, right? Whom do you choose to go? When the pocket, so if we do really get our centers of excellence running, we got cardiology services here, cancer services here, then many people, we can reduce that space. Similarly, Chair, on staff issues, on corruption, one area that we really face a problem, and it's a headache, is recruitment of HSAs. And it's all of you that will come and say to Dr. Namarika. So, HSAs. That's where there's also a problem of corruption. All right. And we need to face it head on. So what is the ministry thinking? I think the challenge with HSAs is that up until now, we've just been getting them direct from MSc. So they just get their first degree or first qualification at secondary school, plus whatever else they have, and we take them. So as ministry, what we want now to do is establish a training program. Training program, because we do have the facilities. So people after secondary school, they should be able to apply to go and train. And then when we are requesting for positions of HSS, should be those that have the prerequisite qualification. I think so we would like to do that. So when we ask later on that we need this training institution we already have a facility in Ponera, another facility in Mzimba, and another in Mwanza. I think those would be our training facilities that we can train prior to recruitment and advertising. So in your constituents, please encourage them to apply to this school. Then they can easily not give you as much problems. Digital is one thing that we need to embrace. I think I will not overemphasize what the digital space can do in human resource management, in supply chain management, equipment, procurements already mentioned here. So embrace digital space. Fortunately, Chair, almost all our district hospitals have internet services. So we can start. Maybe it's the health centers that we've not reached out with internet services. In Rwanda, Chair, one investment, and let me just finalize here. If we're really to review the Malawi, this is just a suggestion, it's not policy, suggestion. If we are to review the Malawi 2063 agenda, all right, my suggestion, two things that may need to be included is digital. If we don't embrace that in all sectors, we are behind. The second one is climate change. So, because that's hitting almost all sectors. So if we were to give an addendum to that, but of course I know that people may say, oh, but that's just my view. But digital is certainly a catalyst for so many, almost all sectors. We may need really to invest in a big way on digital, the digital space. Finally, Chair, what you've demonstrated today is beautiful to the Ministry of Health. You've brought us the district commissioners, and that should be the culture. And I like it that they presented themselves. And I think you've highlighted that they are controlling officers and that they should be interested in service delivery at facility. When we get to the districts, we will always be firstly presenting ourselves to the DC's office, then because he's the controlling officer. So I appreciate that all of them really complied and we're here to support our teams. Thank you, Chair.
All right, thank you very much, SH and the entire team that accompanied you here. As a committee, be assured, we are always there for you. You are our mother, our policy holder, and let's be assured that you will be pushing whatever the agenda that we have, the health financing, the digital health. Very true. The world is talking digital health now. Wherever you go, Zambia, Tanzania, if we don't embrace digital health, then, I mean, there's nothing that we can do. AI is being used in the health sector. If we don't do it, then others will be doing it. Thank you very much once again, SH. And in a special way, let me also thank my members here. They've been here since 9. We haven't walked out, and already the next stakeholder is waiting for us. For these honorable members to be here and have an interaction with you, I think it demonstrates the commitment that they have in making sure that this country moves in a right direction when it comes to issues of health, medical health care. I really thank you, honorable members, and please let's continue on this path as we continue shaping up the health sector. Thank you very much, Honorable SH and entire members. Thank you very much. May God bless you. Thank you.